Welcome, everyone. This is a nice summary panel from ACR 2024 in Washington, and we are going to tell you a lot of interesting stuff. We're going to talk about the JAKs and the TYK2. Are they dead in the water? Are they safe? What's the cool stuff out there? So I'm Janet Pope. I'm a professor of medicine at Western University in London. David, who are you?
Yes, David Lee from Melbourne, Australia.
Michael, who are you?
Mike Putman from Milwaukee, Wisconsin.
Great, wonderful. So maybe we'll start our first round of discussion, and we can certainly feel free to interact. David, do you want to tell me what you thought was interesting with the JAKs?
Well, I'd almost like to hear from Mike first about select GCA and then lead
Let's.
into a bit about PMR, because I'm going to tell you about PMR after that.
Okay, let's do the big vessels before the other ones.
But let's make sure we don't think the PMR is second fiddle to GCA. That's a very
It's not,
controversial topic. No, happy to talk about select GCA. So I was actually a participant in this, although I was not able to enroll any patients. I want to talk about select GCA. This is abstract 0770. This is a nice bracketing because this actually began the meeting for me, and now it is also ending my room now coverage. So it's all coming full circle. But this is a really important study. This is a double-blind, randomized controlled trial conducted in 24 countries of the Janus kinase inhibitor upadacitinib among patients with new onset and relapsing giant cell arteritis. So, ever since the JAK trial, where we realized that interleukin-6 inhibition could help us get away with lower steroids and have a better rates of sustained remission among patients with giant cell arteritis, we've been pretty excited about bringing new disease-modifying anti-rheumatic drugs into our armamentarium. And I think a lot of us are methotrexate skeptical. I would include myself in that. And so it's felt like there was a steep drop-off for patients who couldn't receive tocilizumab or who didn't respond to it. And so I think there's a lot of excitement about this study in particular. This was a big study, and this was a big study that was launched with virtually no preliminary data for the actual molecule itself. And they went right into it. There were 428 people who were randomized, either placebo, 7.5 of upadacitinib, or 15 of upadacitinib. And honestly, it worked. The plenary session was pretty exciting. If you look at the efficacy estimate, the primary endpoint was sustained remission at week 52. So people who got upadacitinib 15 milligrams and a 26-week steroid taper, 46% of those people were in remission at week 52. Compare that with a 52-week steroid taper for the placebo group, 29% remission. So that's a 15% absolute improvement. That's in the context of getting, 26 weeks shorter steroid taper. So, the smaller dose, which I kind of would have liked if that had been an option from a safety perspective, really didn't seem that different. And I suspect that we'll wind up needing to use the 15 milligram dose to get the efficacy that we'd be looking for. So that's one caveat to it. But if you look at all of the different subgroups within the trial itself, they had a nice presentation of the subgroups as well. It looked like across the board it worked for pretty much any small slice and dice you could look at. New onset versus relapsing, and various demographic characteristics, disease characteristics. And then I think just to go to the most important topic for Janus kinase inhibitors, which is safety, there were no new emergent treatment-associated adverse events. It's tough when you look at this is a big study. 430 people with GCA is an impressive undertaking, but it's just not quite large enough to say definitively whether or not we see any of the safety risks that we saw with tofacitinib a couple of years back. So still kind of an open question. I'd love to hear from y'all what you think about either of those topics, either the efficacy of the agent or the safety risks that remain.
So before I commit, if this is approved, which presumably, because he went straight to phase 3, it would be an add-on, an extension of the label. If it's approved, how are you going to decide UPA 15 milligrams a day versus tocilizumab every week or every other week? How are we going to decide this?
That's a great question. So I actually am hatching a scheme to compare them in some kind of network meta-analysis. It was actually a little complicated. So I don't think we're going to get a direct comparison ever in a randomized fashion. Probably not in good comparison observational data for many years. So I suspect there will be a lot of stickiness with tocilizumab because we have experience with that. And this is where the safety really becomes a question. So I approached multiple patients for this trial. It is hard to enroll people into a study when you have to say, this class of medications has been associated with cancer and cardiovascular disease, which are essentially the two least favorite things of the population in question here. And so I suspect tocilizumab will retain quite a lot of the first-line agent status for some time to come. There's some benefits to an oral molecule. I do think that there's quite a lot of patients who would benefit from this, who maybe didn't benefit entirely from tocilizumab, or who preferred an oral agent, various other reasons. But I actually suspect that tocilizumab will retain its kind of first-line status for a while now. What do you think, David? I'm curious to hear your thoughts.
Well, it's something that I've kind of ideas I've thrown around with others around the place about this. I feel like we'd love to get to the situation where we could phenotype patients well, and there's enough heterogeneity in GCA that we might be able to do that, and then be able to select an agent, not just on the basis of the general characteristics of a patient and what it might mean for their safety, and then the individual characteristics of the therapy, but the actual characteristics of the disease itself. And I guess if you think about maybe if part of the appeal of something like upadacitinib is that by virtue of the pathways it affects, potentially it might influence intravascular complications more, if I can assert that. And I guess we've seen data from imaging studies and from histopathological studies that maybe tocilizumab might not have the same effects on large vessels on an ongoing basis that we might like. Then plausibly, the patients that are less likely to have aneurysmal changes or have other intravascular complications might go to tocilizumab. Others might go to upadacitinib. It'll start to get interesting though when you start throwing. Well, we've got G-Captain, which we'll probably report soon for secukinumab. So once we start throwing other agents in there, it's going to start to get to be a little bit crowded compared to where we were. And I say crowded, but Tossi's it's been 8 years now since a JAK got presented at ACR. So it's had an 8-year head start on this. And now we're talking about a second agent. So it's not that crowded, but there's enough opportunity there for us to start to think about strategies. And it's a really exciting time. We've seen it happen for RA. We've seen it happen for PSA. I mean, perhaps we can reflect on the lessons we learned from those diseases and think about how we might take a strategy approach for GCA.
I love it. I think the bottom line is there will be regional differences, country and county and state differences, and that the marketplace over time will, by a satisfaction, we can get easier access to this, or this one seems to work faster, or I have less people flaring when I stop the drug. I think all those things that we won't know till they're in the marketplace to compete with each other, I think that'll end up making our decisions for us. But right now, I think it'll be, in a good way, a free-for-all. Just let's use a steroid-sparing drug, go to town. If it doesn't work, try a new one, and look at relative or absolute contraindications. Yeah, great. It's an exciting time. So leading from the GCA to the PMR, David, what are you going to tell us about?
I'd like to tell you a little bit about the Bachelor study, which is from our colleagues in Brest in France, Brittany. So that's Alain Sorot and Valérie Dechevel-Pinsec, and their whole team. That's abstract 0858. And this team have worked over time on looking at treatments particularly for newly diagnosed PMR. So back some years ago now, they looked at tocilizumab in that context in the Tenor study. And then after that, more recently, they published data from essentially a phase 2, investigator-initiated phase 2 in abatacept, the Allure study. And so Claire and I wrote this editorial on that study, talking a little bit about the difficulties about trying to differentiate newly diagnosed PMR versus established refractory PMR, and the therapeutic approaches to both. Because, and it's interesting that this came up in the presentation as well, because this study looks at newly diagnosed PMR. And a newly diagnosed PMR, I guess if we think about our classical PMR therapeutic approach, steroids up front, you wean, and then maybe you hit some sort of floor, up or down, you hit some sort of floor. And in some ways, that resistant period is quite different to that beginning period. And so I meant to give you this really long introduction because this is kind of what they've thought about in this study. With baricitinib, we've got a 4 milligram tablet, a 2 milligram tablet in some jurisdictions. And what they did here is that they had 12 weeks of 4 milligrams, 12 weeks of 2 milligrams, and then nothing for another 12 weeks and compared that to placebo. And obviously, perhaps, completely unsurprisingly, baricitinib absolutely smoked placebo. So at 12 weeks after, 12 weeks of 4 milligrams, it was, in terms of the primary response, was 77% versus 13%. After you drop down to 2 milligrams for another 12 weeks, 88 versus 14%. But I think the really impressive bit is that once you stop, and so that's only 24 weeks overall of baricitinib, we're looking at 76% versus 14%. And that's an effect size you can write home about.
Yes.
So, really what we're talking about here is that if you've got safety concerns about baricitinib, and you won't know from a short, phase 2 trial, like investigator-initiated phase 2 trial like this, but we're only talking about 24 weeks of exposure, of which half was at a half dose. And I think people have concerns about cardiovascular and cancer risk with JAK inhibitors in PMR, potentially, or maybe even cost of JAK inhibitors in PMR. But a short, abbreviated approach might deal with both of those things.
It was really a brilliant study design because it was 4, then 2, then off, and still showed, as you say, a huge effect in steroid sparing. Contrasting with the methotrexate, did not show any steroid sparing in PMR. So PMR new, so de novo, methotrexate plus pred versus pred alone was, in my opinion, nail in the coffin for methotrexate, at least with de novo. I'm not saying problem patients later, but in PMR it did nothing. So the big contrast of the Berry study that was done. Mike, any thoughts on this? You're going to change your behavior?
No, I ping off of both of those. I mean, I have long been methotrexate skeptic in both GCA and PMR. There was a sort of encouraging trial published in Annals of Internal Medicine quite a while back, I think like 2009, for methotrexate that I don't think it might help some, but especially in GCA today has been pretty underwhelming. And so I am often skip straight ahead to anything else in PMR. The baricitinib study was quite interesting to me. I enjoyed the presentation of it as well. David, my question for you. So we have all these agents coming down the pipeline, and I think our historical PMR taper was somewhere between 9 to 15 months, depending on who's running the show. How is this modulating your approach to steroid tapers in PMR? It's a tight issue. It's a tough thing to decide.
This is a great question. And I've heard you talk about this before. I've had conversations in the last 24 hours about this. I think in the context of these data, I think what's clear is that a single steroid taper for everyone is unlikely to be appropriate. Some people clearly can go faster. Some people clearly need to go slower. And right now we're poor at differentiating who does what. It does make us, if you go back and you think about how we came to the point that we have, and I think if you look back at, say, not that long, maybe 20 years ago, about Marco Cimino's work on trying to figure out optimal steroid dose at different points in time, I think now we've got more data and the capacity to generate more data to actually not just only think about a quicker steroid taper as the base case, but then also really trying to get the characteristics and build a strategy on this. What we really need, of course, I think, is a study that has multiple arms that compares faster steroid taper in the context potentially of JAK inhibitors or other things that you might use in early in newly diagnosed PMR, and build a strategy from there. Now, of course, that's wishful thing. I hope some philanthropist comes up with some money to put this down on the table to fund this study. But I think that there's enormous potential for a common condition to be able to change a lot of lives if we get a better strategy. Because I'd argue right now that newly diagnosed PMR is probably the biggest cause of steroid addiction in medicine, and we need to try and do better on that.
Yeah, I love the word steroid addiction. And just, I guess, a question on all this that we can't answer today is, there was I think it was a study from China, multiple sites in China, RCT of tofacitinib, 5-BID, no steroids in PMR versus steroids. And it was actually statistically and clinically relevantly better. So, JAKs might have a role where it's a very rapid steroid taper. And I mean, the biggest biomarker for me is, I guess, if they're achy again and it sounds like it's the PMR as opposed to mechanical back pain and shoulder tendonitis achiness. We just go up a little bit and go down a bit more slowly. But I mean, these are really, what we're talking about is going to change practice. So I'm going to shift gears for a second. I want to talk about something we don't talk about that much on Rheum now. So inflammatory myositis. And it's really, I'm being JAK focused. So there might be other cool stuff, but I'm concentrating on the JAKs. So the first abstract, 0348, was on upadacitinib, 15 milligrams a day, and showing that it could be effective in inflammatory myositis, including our traditional synthetase, but also the MDA5. It was a small-ish study, but did show some pretty good benefit, uncontrolled, selection bias. Some of them had failed a lot of drugs. So then looking at a bigger study, number I think it was 1736. It was an oral presentation. So it was looking at tofacitinib in inflammatory myositis, failing some stuff, comparing it to using the CNIs, so tacrolimus or whatever other CNIs. And it was a large study, but it wasn't like, just to know there could be channeling bias. It wasn't randomized, but it was 290 patients inflammatory myositis on tofa and 225 on the CNIs. So quite impressive numbers. And they showed survival and benefit overall better in the TOFA group than in the CNI. So very interesting. I kind of wish if they had known their ends would be that large, that they would have done the protocol forward thinking and randomized or cluster randomized. But I mean, that was very telling to me that when I'm in trouble with my myositis patients, especially these MDA5, because they could die rapidly of their lung disease, if we can improve survival on one product class compared to another, it might really change my practice. Of course, not approved for this. So, it's an off-label thing and no RCT in that. So then it takes me to a wee little RCT number 1731, baricitinib. 4 milligrams a day. And there's a problem with this trial design, but first of all, it was 15 patients, investigator initiated. They got a grant from Lilly to do it. Probably took a long time to enroll. So these people had to be recalcitrant. So inflammatory myositis, more dermato than poly, but basically either could have gotten in. They had to have failed a couple treatments to get in. So at least 1 or 2 advanced therapies, and of course, failing steroids where you can't get it down. So, okay, all that makes sense. N of 15 doesn't make any sense to me, but whatever. Let's see what they did. So they did, if you remember the RIM study, which was rituximab and myositis, where it was rituximab versus rituximab at the end of the year. We don't know who wins because they all got rituximab. It was the same design, sadly. So what they did was, so they denied you adding berry for the first 12 weeks in one group, or you got it from day one when you signed the consent. Then at 12 weeks, everybody's still on baricitinib for another 12 weeks, and the outcome is at 24 weeks. So does berry holding it for 12 weeks make any difference by giving it at 12 weeks to 24 or giving it at 0 to 24? And the answer is nope. Doesn't make any difference. But what they did do, and that wasn't in their abstract, but was in their oral presentation, they actually presented that at 12 weeks of berry, so the second group who got no berry, was, I think, clinically relevant and statistically better. The lead time of getting berry early was starting to attenuate by 24 weeks. So I think their outcome measurement was at the wrong time. And the way the guy presented it, it was the 12-week data, certainly in my mind, showed that berry in these difficult to treat patients at 4 milligrams a day seemed to make a big difference. So my take home is I'm going to think about JAKs more, 100% off label when I have problem patients. I'd already thought of it with calcinosis, and my results on calcinosis in these really problematic long-standing dermato patients is that it probably takes a heck of a long time first you sort of stop getting new ones, and then maybe over many months, or even in my opinion a couple of years, you start breaking down the calcinosis more. So let's open it up. Any experience or any thoughts about either the studies or your own practice? Is this a game changer or not?
My own practice, I've actually been JAK curious and myositis for a while now. There was actually quite a strange study published in 2019 in the New England Journal that looked at tofacitinib among patients with MDA5, and it compared patients who got it to a historical cohort. So kind of as you've alluded to, the science in this area hasn't been quite as solid as I would like, but it at least got me curious about it. An interesting group where I have tried it with some success is actually patients with antisynthetase syndrome, and especially have refractory sort of joint pain symptoms, where I feel like that's one of the main phenotypes where I wind up seeing that. And I've had some people who responded quite well to it. There is actually a phase 3 RCT of brepocitinib that's starting now. It's a TYK2 JAK1 inhibitor for patients with dermatomyositis. And so, I'm always excited when I see that there will be a more definitive study coming down the pipeline. And I think that was pretty interesting. One of the things I looked up while I was at the meeting to find out if there's something we could participate in.
Yeah, no, I love your take on all this. I think also Jack's work on skin for dermato takes a bit of time, but it seems to, because again, we're only doing the recalcitrant treatment kind of patients. David, any other take on that?
Yeah, I mean, I think it's the other thing, which is probably a very small patient population, but has been discussed a lot, are the MDA5 patients who, tofacitinib seems to be potentially the most promising therapy in a really high mortality, difficult to treat population. We've had some kind of local success with that, like in N=2, but I think that we're starting to see more data generated on that. I think at the same time, there's been a bit of work on UPA in myositis as well, on general IIM. So I think in between those two extremes, we're going to be able to find a few different off-label indicate pathways to getting JAK inhibitors for myositis patients, and it is one of the conditions where still, despite more data for IVIG and despite kind of other attempts at steroid sparing, we still use a load of steroids in myositis patients, no matter how you splice or dice it. So I think there's a need there. There's clearly a need there. And then the one thing, generic TOFA could potentially change it all, and that probably applies to everything.
With less cost for most countries once it's generic for an oral small molecule. Let's switch gears. Is the safety put to sleep now of JAKs and TYK2s? Whichever one wants to give the opinion first. Are we worried, not worried? Oral surveillance almost didn't come up. There were only a couple of abstracts on that. I was kind of relieved. Whoa.
Dave, I'd like you to start. I think we think it's been put to sleep, but in opposite directions. So why don't you give your case first?
I think so. I mean, there's still ambiguity, right? And I think that we will have more data that will come in due course. And I think the next one to see will be the baricitinib post-marketing requirement. And so what we'll have when we have those data is, first of all, we'll have 2 randomized control trials to look at safety. And that will be helpful in trying to validate a signal. We'll have it across 2 different agents. So I think the risk that this is a chance or that this isn't a class effect will start to wash out a bit more then. So as much as we've got a break from talking about oral surveillance now, then soon enough we'll be talking about it again if we've stopped talking about it. I think we still are, as much as we haven't talked about, there were enough posters about JAK inhibitor safety to make me think that we still haven't fully thought about the implications of JAK inhibitor, of how to process JAK inhibitor safety in our everyday practice. I think we still bias one way or the other. We still use heuristics that kind of push us probably away from where we need to be. So without trying to sit on the fence too much, I think that we probably are starting to. We've gone through the hype curve. We went all in on JAKs and everything was great. Then safety data hit. We went the other way. I think we're getting to the nice middle bit where we're using it with the equipoise it needs. So having said that, you throw some more data that will come out there, and I'll probably swing the other way, and we'll be off balance.
You're making a decision, but it is a hedge, and that's quite okay. Mike, you're on tell us where you're sitting.
I think that's very well put by David. I like the historical perspective on it. So I'll give a different my current approach to how to implement these. I remain convinced by oral surveillance. I think that tofacitinib among patients with cardiovascular risk factors There's a risk for cardiovascular disease. And I think that there's a real risk of malignancy, certainly in folks who are older. So if I start tofacitinib, I always say that there is a definitive, it's a small risk, but it is a real risk. And I think that people need to be informed of that. My baseline assumption is that this is a class effect. I think that the JAK inhibitors are certainly different, and there are different selectivity among the JAKs, but there's bleed over, and I think it's implausible that there'd be a large difference. Now, the flip side is there doesn't have to be a large difference. If there's a small difference based on the selectivity, it's possible that one that was more selective in one direction or another could be less risky. So I think that some of the observational data, I think David covered a really nice job covering a meta-analysis that looked at this topic, has made me feel like perhaps I should give more credence to that than I have been. And so if I'm starting a more selective JAK inhibitor, I will say something like, I do think that this is likely to be a class effect, but it may not be. And so I think that can be helpful. And then I actually don't expect this to necessarily extend into some of the less JAK ones, like the TYK inhibitors. I don't think we've seen that signal. And I think those are sufficiently different that I wouldn't be as comfortable labeling that as a class effect there. Ultimately, this is kind of I think the companies ought to run the trial if they want to exonerate the drug. And so I've been advocating for that. I don't think it's going to happen for all of them, but I'm looking forward to some of the data that's coming down the pipeline.
You're raising good points. So my take is, what if really all our treatments reduce cardiovascular events, but some reduce it more? So that's my take. For cancer, it's harder for me to say that our drugs reduce cancer and that one reduces it more. I really don't have that paradigm, but I'm pretty certain in my own made-up view of the world that JAKs don't increase cardiovascular risk. It's just for some reason TNFs or certain TNFs probably reduce it more. But it's a take on the data. It's still seeing a differential that's there, and you can't explain it away. So I think before we say it's a wrap, to let the audience know that deucravacitinib in psoriasis, FDA said you have to do a trial to look at cardiovascular, infection, and malignancy. So we're going to have oral surveillance by a different name of deucravacitinib, different disease, psoriasis. And I'm not sure what the comparator is. So I think we will get something more definitive there, but it's unrealistic to run studies for 4 to 10 years as the patent clocks tick on all these drugs. So you either are in with a generalization, or you run your study and you say, I'm lucky to be different, or I am different, or I'm not different. So I think that's kind of a wrap on what we're thinking about. I think the final thing is, as a positive, is with all these new potential indications, GCA for a JAK, PMR for a JAK, maybe inflammatory myositis when the actual RCT is done. I think that will help reassure us that there's still unmet need, and a whole bunch of prednisone always has more cardiovascular risk than almost any other drug of a rheumatology drug that I would give the patient. So I think we can always say, if we can do better to control the disease and lower the glucocorticoids, we're going to have a better life for our patients. And of course, we'll have 2 big trials in lupus that will get some data to both UPA at the higher dose, 30 milligrams. That's a dose that is used in induction and stuff in IBD, and also deucravacitinib at the regular dose. So more will come. Any last words before we sign off, gang?
Well, I'm glad to see that we're going to eventually get more data on Ducra and safety, because I think it's potentially an enormously useful drug. We saw some data at this meeting about persistent effect of Ducra in different indications. I heard Mike talk about it very articulately. I think it's, just because TYK2 is a JAK doesn't necessarily mean that a TYK2 inhibitor has the same issues as a JAK inhibitor. Like I was saying to you guys before, a race car and an ice cream van are both petrol-powered vehicles. Doesn't mean that they have the same safety risk. And so I think if Duca has good safety, like potentially it seems from the clinical trial program, then it could be an enormously useful drug as add-on therapy across a number of different indications. I think, cost aside, I'm quite excited about it as a therapy, more so than I thought I would be.
Yeah, I don't think I can beat either of those for I don't think I can beat out of those for final thoughts. Prednisone's the worst, and an ice cream truck
Yes.
analogy. But
Yeah, that's our
yeah,
final bottom line. Prednisone is
my
bad. It's good
yeah,
enough, but
I'll
mostly
give
good.
my final 2 cents, which is that when I was told someone I was doing this panel tonight, they said, isn't the conclusion that JAKs just kind of work for everything? And my first answer was like, yeah, I guess every single time we've tested them, they seem to work. The SLE Brave, but mostly across our diseases, they seem to have some efficacy. I think the real task of the coming 5 to 10 years will be defining where they're the first line and where they're a clear second or third line. I'm excited about data in psoriasis, but we were talking earlier about, is that really going to go head to head against the 23s? And, in rheumatoid arthritis, I mean, the JAKs are fantastic. Where do they land for myositis? Questions like that are the things I'm really going to be looking forward to finding out.
So people are going to have to keep following us at Room Now as we cover meetings, and we'll get the answers. So thanks. It's a wrap.